He's the third one down.
Yes. Second, Al-Mufti. Yusuf Mufti.
Good morning, everyone. My name is Yusuf Mufti. I'm a medical student at the University of Texas Health Science Center at San Antonio. Today I'm going to be discussing an innovative technique for external iliac artery reconstruction in renal transplant patients with extensive atherosclerosis. I'm going to highlight a challenging case where conventional vascular clamping was not feasible. I have no disclosures. So renal transplantation is the preferred treatment for end-stage renal disease, but organ shortages and increasing demand present major challenges. Severe atherosclerosis, which is a very common comorbidity in this patient population, complicates transplantation further. You have these calcified plaques in the external iliac arteries that make controlling blood flow very difficult. The rigidity and fragility of these vessels is very great, and conventional clamping can lead to vessel dissection or occlusion and irreversible damage. So there's several techniques to get around this. There's stenting, endarterectomy, bypass, anatomic reconstruction, but these typically rely on proximal and distal clamping, which was not really feasible in our case due to the extensive circumferential calcification. For those of you who are interested, there's a recent 2023 study which reviewed 18 atherosclerotic kidney transplant patients who underwent revascularization before transplantation using various techniques, including vascular prosthesis, stenting, angioplasty, endarterectomy, and bypass. Results showed that vascular repair was safe with survival rates of 94% at 1 year and 85% at 5 years, but pretty limited study, very small sample size. So our patient was a 54-year-old male with type 2 diabetes, coronary artery disease, ischemic myopathy, and pulmonary hypertension leading to end-stage renal disease. He was listed for a dual cardiac renal transplant following heart failure. Successful cardiac transplant was followed by renal transplantation, but intraoperative complications due to extensive iliac artery calcifications that made traditional clamping impossible, and vascular surgery was consulted intraoperatively. So in response, we adopted an innovative technique involving intravascular balloon occlusion for vascular control. The vascular team began by obtaining ultrasound-guided access to the right common femoral artery, followed by catheter advancement to the abdominal aorta to visualize the iliac arteries. A 10 by 20 millimeter Mustang balloon was then inflated to occlude the proximal external iliac artery via contralateral access. A 7 French Fogarty catheter was then inserted through the conduit and through the arteriotomy for distal control, preventing back bleeding. We then performed an end-to-side anastomosis between the external iliac artery and the cadaveric conduit, which was used to connect the donor renal artery. Really only a short segment of the external iliac artery was suitable for anastomosis, as most of it was heavily calcified. The cadaveric conduit was connected with balloon control proximally and distally, allowing for careful flushing to prevent embolism, and intraoperatively signs of perfusion were evident. So postoperatively, again, immediately, his left lower extremity pulses were palpable. By post-op day 13, Doppler imaging showed very good flow, sufficient renal perfusion. By post-op week 4, again, he had some delayed graft function and slow renal recovery. He was discharged on dialysis. That's pretty typical for a deceased donor renal transplant like this one. But now he is currently no longer on dialysis. So what can we learn from a case like this? Were there other options? Well, there's bypasses, but it's a 2-stage procedure, which wasn't really possible in this case since vascular surgery was consulted intraoperatively. There's anatomic reconstruction of vessels, which is really only possible with clamping of the native vessel. As previously stated, that's not really possible. This is a pretty unique case. We had only that 1.5 centimeter length of external iliac that was suitable for anastomosis. The rest of the vessel had pretty extensive circumferential calcification, but there wasn't really any stenosis. So, this balloon technique was a really good option, and it ended up working out really well. So, and intravascular balloon occlusion provided effective vascular control in a single stage, reducing surgical complexity and ischemia time compared to 2-stage bypass, and conventional options weren't really feasible, allowing for a very good outcome in this patient. Thank you all for your time.